Okay, I think we can go ahead and get started. Welcome everyone, hello. My name is Sabrina Sholts. I'm a biological anthropologist and the curator of the exhibit Outbreak, Epidemics in a Connected World at the Smithsonian's National Museum of Natural History. I'm joining you all today, not from the museum, but from my home in Washington, D.C. On behalf of the museum, it's my pleasure to welcome you to the final webinar in our series, Vaccines in the Time of COVID-19. Over the past month, we've discussed the development, testing, manufacture, and distribution of vaccines, and particularly those for SARS-CoV-2, the virus that causes COVID-19. And today our program is Vaccines and Society. It's going to focus on vaccines in a societal context. And so we're really delighted that you can join us for this really important topic. For more than 2 years, we've been educating the public on viruses that spill over from other animals, pandemic threats, and One Health through the Outbreak exhibit and its associated programming, like the webinars that we're bringing to you today. I always take every opportunity to thank the many people and organizations that made this possible and supported all this work, including those that provided funding. So thanks to you all. In today's program, we are going to hear from an expert whose research considers questions of risk perception in medicine. But before we begin that program and that conversation, I'd like to acknowledge current events and let you know that the National Museum of Natural History stands with the Secretary of the Smithsonian, Dr. Lonnie Bunch, in expressing our deepest sympathy to the families and communities impacted by discrimination and violence. We'll be sharing Secretary Bunch's response to these events, as well as a resource developed by our colleagues at the Smithsonian's National Museum of African American History and Culture. Their portal, Talking About Race, is designed to provide tools and guidance to inspire conversation about race and empower your journey. And so we'll share those links with you in the Q&A. Note that the Q&A box is where we'll be communicating with you throughout the program. We'll post other links as they come up in the discussion, and that's where you can submit your question for our speaker. Take a moment to locate that Q&A box, which should be either at the top or the bottom of your screen. Type your question in there, and we'll do our best to answer as many of them as possible. And if you want to, include your first name and maybe where you are joining us from in the world. I'd be happy to share that information as well. So now that that's out of the way, let's get started. I would love to introduce you to our speaker, Dr. Sharon Kaufman. Dr. Kaufman is a medical anthropologist and professor emerita in the Department of Anthropology, History, and Social Medicine at the University of California in San Francisco. Her work explores topics at the intersection of medical knowledge and society's expectations for health. She's examined the changing culture and structure of medicine, healthcare delivery at the end of life, the relationship of biotechnologies to clinical practice, and the shifting terrain of evidence in clinical science. She's also investigated vaccine doubt and hesitancy among parents of babies and young children, paying particular attention to how citizens interpret risk in medicine and everyday life. Thank you so much for joining us today, Sharon, and please take it away.
Thank you, Sabrina, and thanks to the Smithsonian. It's a pleasure to participate in this series. We've learned in these presentations about the virus in relation to vaccine development, safety, and the challenge of rapid distribution. My remarks are picking up from where some of the listener questions left off last week. Today, I want to broaden our view and shift the focus from the virus and the work of scientists to us, the herd. For this pandemic, any pandemic is a social event as well as a biological event. The virus only has one goal: to find human bodies and replicate. It responds to human behavior and it links our bodies to one another. I think we've all seen in the past weeks and months exactly how this works. When we socially isolate, wear masks, and wash hands, the virus has trouble finding new hosts. The number of new infections goes down. When we gather in large groups without masks or live and work in crowded conditions, the virus finds plenty of bodies and the disease spreads. This has been most apparent in the spread of the virus in nursing homes, meat packing plants, and in states and communities that have opened bars, restaurants, malls, and beaches to crowds of people while the case numbers are still rising and before there's any immunity. A recent example from Northern California, where I live, is San Quentin State Prison, overcrowded with 3,500 people. They had no cases of COVID until 14 infected individuals from another prison were sent there. 4 weeks later, 1,400 prisoners have the virus and 200 of the staff. There have been 7 deaths. This is as of last week. The way the virus is still spreading in the United States dramatically exposes the many fault lines in our country. Our diversity in politics, class, race, job security, and access to healthcare has brought these differences into clear view, revealing many tensions that have culminated in our widespread demands for social justice. I want to mention just 2 of these tensions. First is the tension between the need for so many to go back to work versus the urgency of social isolation to stop the spread of disease. This tension may be impossible to resolve fully. Glaring statistics show us that those who must work outside the home, those in our essential services of healthcare, domestic care, garbage pickup, food production, those who are in contact with the most people through their job are the hardest hit by the virus. Our economically unequal and essential workforce, mostly people of color, especially African American and Latinos, bears the brunt of this devastating virus on income and health. We have a second tension, growing and spreading in various sectors of our society. This tension is between the need for the common good, for a sense of shared responsibility on the one hand, and on the other, the desire for the freedom to act autonomously, to do whatever we want as individuals in a free society. The collective versus the individual. This pandemic illustrates how connected we are to one another, and it shows how the behavior of one of us influences what happens to others, perhaps many others. Both these tensions are increasingly displayed when it comes to vaccination. At a large anti-vaccination protest rally at the California State Capitol on May 1st, a spokeswoman noted that although many of the protesters there were anti-vaccination, they weren't primarily anti-vaccination. They just wanted their freedom. The demand for the freedom to do anything and to resist any and all restrictions, even wearing masks, is being powerfully expressed to the point of violence, unfortunately, under the pressures of COVID-19. Strident anti-vaxxers and far-right groups joined together at that event in California and now joined together at other events happening around the country with greater frequency. These groups express pushback regarding any kind of vaccine at the same time as they voice their outrage and demands in response to any restrictions on personal behavior. What has emerged most recently and alarmingly is a seemingly endless flood of anger toward public health. In California, as of 2 weeks ago, county public health officials are being harassed, threatened, and some have received death threats, causing a great deal of worry among health officials and distracting from the messaging of health advice. While vaccine and health information protest groups constitute a minority, and I want to emphasize that, they're exceptionally vocal in their demands and sometimes their hostility. Without strong leadership that is scientifically informed, without a national consensus of trust in medical expertise, people grasp for some feeling of personal control, now lost with the pandemic. There's no question that trust has been diluted through political partisanship and conflicting, often changing messaging about how to respond to the virus. When trust disintegrates, people are thrown onto their own opinions and resources. The attitude, every man or woman for him or herself takes over. As we travel this rocky road, it's becoming increasingly clear that the virus is only half the problem. The other half is the response of the herd, our collective actions. Perhaps as our response to COVID-19 evolves, it can teach us something constructive about addressing the inequality in so many spheres of our society and the deep skepticism and anger woven into the fabric of our country. We need a vaccine, and the majority of Americans anxiously await one. The latest polling I saw, reported by Johns Hopkins University on July 1st, showed that 70% of Americans would take the vaccine. Yet it's apparent that scientific facts alone do not and will not convince everyone to vaccinate. Given the depth of these social hurdles, what do we already know about the roadblock attitudes toward vaccines that are likely to hamper uptake when a COVID vaccine is here? We know that doubts and misinformation about vaccine safety abound. This is not new. There's always been skepticism toward vaccine science, and more broadly, skepticism about unfamiliar risks. We can see this in two realms. First, pushback of some people against childhood vaccines and annual flu shots has been apparent for years. These will remain in play. The question, is inoculation worth the risk, emerged broadly for parents of infants and young children in the 1990s, when a rise in diagnoses of autism coincided with an increase in the number of routine childhood vaccines. That question, although it had been asked, had never been asked in such a widespread way before then. The concern about risk that underlies that question has not abated. Instead, that concern has become part of the cultural landscape. Parents of young children today talk about risk a lot, and they provide a stark example of risk awareness and risk aversion in our society. Risk assessment and risk reduction in health, as in so many aspects of our lives, has become a central preoccupation, really, for all of us, and it influences our behavior. Our awareness of environmental risks, particularly climate, infectious disease, toxins inside and out of us, grows more pronounced each year. One could say that to be a citizen of the US or of the world today is to dwell in risk. This sensibility is unavoidable. It's the air we breathe. Yet, childhood immunization rates in the US generally remain high overall, near 95% for many of the vaccines. But a large enough minority of parents in some US communities consider all or some childhood vaccines unsafe or too risky, and their doubts and hesitancy guide them. That thwarts their community's ability to achieve the herd immunity necessary to contain outbreaks for certain diseases. The recent measles outbreaks in the US following its elimination in the year 2000 is a prime example. For measles, 93 to 95% of a population must be vaccinated to achieve herd immunity and prevent an outbreak. In 20 states last year, the vaccination rate was below 90%. Acceptance of the annual flu vaccine faces many of the same hurdles. Doubts about its effectiveness and belief that it's unimportant or unsafe were the main reasons cited in studies tracking the overall decrease in US flu vaccination rates in recent years. A CDC survey for 2018-19 indicates that 45% of adults age 18 and over received this season's flu vaccine, although the proportion of adults over 65 was a little higher. But this overall low response was in the face of an influenza death toll the previous year of 80,000 and consistent urging by healthcare providers that children and adults get an annual flu shot. Physicians and public health experts who grappled with combating vaccine refusal have learned that pitting science against misinformation cannot alone restore trust and cannot raise vaccine rates among some individual groups. Neither can repeatedly providing accurate information. Studies of risk perception show that most of us rely on intuitive risk judgments, not experts, when we're deciding what to do. We rely on intimates in our social circles to guide us, and now many rely on the internet platforms that we are likely to resonate with. Any new evidence presented by experts is considered reliable if it is already consistent with one's initial beliefs. A sense of diminished personal control, together with unknown future scenarios involving jobs, illness, and individual freedoms, serve to bring like-minded people together in communities of feeling and action. This adds ballast to the search for targets to blame. The second realm of doubts and misinformation is, of course, the political arena. The question, are vaccines safe, has become highly politicized. In 2019, members of the House of Representatives Energy and Commerce Subcommittee on Oversight and Investigation posed that question to health officials regarding the measles, mumps, rubella vaccine. Congressional leaders asked this question about arguably the most important public health measure of the last century. The fact that they asked it at all illustrates an extraordinary gap in basic medical knowledge by some in American leadership. It also illustrates the strength of the negative influence of political partisanship on responses to the pandemic. One result of the combination of ignorance and partisanship has been a proliferation of online and cable news sources proclaiming the threat posed by vaccines. So the pandemic crisis is also a crisis in believability and trust. In a crisis such as this, political power can exercise a reckless influence on health behavior. Rumors of diseases brought by hostile foreigners or created with malicious intent have been around for as long as plagues have existed, and historians have written about how rumors of disease brought by hostile foreigners were present in Roman times. Xenophobia and conspiracy theories are a tradition in the United States. Regardless of the sound scientific evidence aired and displayed in many media outlets, misinformation sites find larger, eager audiences, and with them, the potential grows to hamper vaccine acceptance. Fictional claims about the coronavirus, its potential treatments, and a future vaccine have been gathering momentum since January of this year, and I'm sure many people here have seen these. For example, the virus was deliberately introduced to the public by the American government, or it was a CIA plot, or it was spread by 5G technology telecommunication towers, or cocaine cures COVID-19. There's many more. While exact numbers of people who follow the platforms that promulgate erroneous messages are hard to come by, there's over 100 of these platforms, and their variety and reach raise concerns about whether hostility toward the coming vaccine will make broad-scale immunity more difficult to achieve. We do know, unfortunately, that anti-vaccine sentiment indicates the tenacity of the scientific mistrust in our nation. So given all this, how might we prepare for the potential escalation of such roadblocks when there is a vaccine? We're all public health workers in the sense that each of us contributes to the health of the public during this crisis. Vaccine uptake rates are likely to be uneven across the country, perhaps indefinitely. Race, class, religion, historical experience of medical neglect or experimentation, age, and occupation all shape our nation's experience of this coronavirus, and all will contribute to vaccine acceptance. Well-crafted messaging among our diverse communities that isn't condescending or racist will be critical. In this moment of our broad societal call for social justice, messaging needs first to build trust and be sympathetic. Ideally, health providers are part of local communities, but if not, they must be sensitive to local challenges and listen to the best ways to meet those challenges. In addition, local messaging needs to be accompanied by government leadership at all levels that provides enough resources, of course, to meet community needs. These are all big challenges. The unique nature of this virus presents opportunities to build partnerships with minority groups, especially those previously left out of the strategic planning of public health initiatives. For example, Latinos, African Americans, and Native Americans, among other groups, can and should have a voice in framing rollout and acceptance strategies for their communities. Community leadership would go a long way toward providing access to the vaccine, encouraging uptake, and meeting the needs of long silenced groups. When an approved safe vaccine is available, and I think I need to add if, our fragmented citizenry will be excruciatingly sensitive to whether the proposed distribution system seems fair or instead contributes or appears to contribute to deepening our already existing health inequities and attendant racism. I raise some questions for all of us public health experts to ponder. What is fair, and who says so? Among those who will want a vaccine, some groups may complain of discrimination if they feel they've been shunted to the end of the line or have limited access to it. We know already that public hospitals in poor communities do not have the resources available to treat COVID patients in the same way as do well-funded institutions. Will poorer communities be resourced adequately to deliver the vaccine? To ease and organize a rollout, priority groups will be given the vaccine first. That's one thing I think we can count on. Most certainly healthcare workers, probably residents and employees of nursing homes. But who else will be considered essential workers? And who among the most susceptible to disease will be next in line? The elderly, people who are homeless, those who work in food production, or those in prisons? And then which group will be last? Maybe children? Might there be a lottery system? If the vaccine becomes mandatory for school or work entry, will some be outraged by the perceived threat to their individual freedoms? Even if we're not able to vaccinate most of the public and achieve herd immunity, prioritizing vaccines for some groups can significantly reduce morbidity and mortality and thus slow the transmission of COVID overall. And Dr. Paul Offit mentioned dampening as a more realistic goal, perhaps, than national herd immunity, a more realistic goal than wiping out the virus. Vulnerability to the virus will vary by community in the United States and by region in the world. In the US, each county is likely to weigh the concept of most vulnerable differently. Defining vulnerability and priority will be an ongoing debate. The CDC and its advisory groups are already struggling with these questions, and I do hope they open up some of their advisory groups to public debate. We can be sure that there'll be no perfect solution. Until there is global large-scale immunity or immunity in the most important communities, we can anticipate ongoing localized outbreaks of COVID-19, which can be contained if there are smart political and public health interventions and smart citizen behaviors that thwart rather than replicate the virus. But the ultimate roadblock is that even though a COVID-19 vaccine does not yet exist, it has nonetheless become a hot button symbol and perhaps a scapegoat for many things Americans feel, from fear of the unknown to technological risk aversion, to loss of control of the present, the future, and the safety of oneself and one's family, to anger at perceived government overreach, and to disdain for medical advice and expertise. Even before it exists, the vaccine as symbol is loaded heavily. It's already achieved a far-reaching power. Broad acknowledgement of this reality will, one hopes, go a long way toward determining the future relationship of public health to our behaviors and toward shaping the future of this pandemic. To end optimistically, I'm hopeful that this pandemic can move us as a country to a greater appreciation of having well-resourced and equally distributed public health infrastructures at every level, federal, state, and local, infrastructures that can prepare us for the next health crisis. Perhaps this pandemic can also remind us of the importance of scientifically literate leadership and the imperative in a democracy of having a scientifically informed American public. Finally, I hope this pandemic brings home the fact that we are deeply connected to one another in sickness and in health. Our individual bodies are not independent. They're joined in the body politic. Our health depends on the choices we and others are making. Thank you.
Thank you, Sharon. That was so thought-provoking. And you've made some really great, important points here. Thank you for ending on a positive note. The problems that you're addressing are no less enormous than so many others that we've been discussing through this series. And you provided some really helpful information and ideas and raised some, I think, really critical questions. I'm glad that we get to discuss some of it. I would first like to ask you, in reference to your suggestion of ways that we can craft better public health messaging, right, that's sensitive to local challenges and needs and that engages communities. Do you have any examples that you've seen where that's been successful, or perhaps any examples that aren't or haven't been?
Well, I think in terms of the measles outbreaks, 2014-15, and then last year, 2018-19, these were definitely confined to specific communities that more or less cling to themselves and that follow the opinions and advice of leadership in their communities. And also these are communities that gather. So I know among one of the Orthodox communities in upstate New York, the ultra-Orthodox, where they were gathering in very large groups, both in terms of the coronavirus, but also in terms of the measles outbreaks previously. When people went into that community and spent time there, when public health leaders from other parts of the state went in and really spent time face to face, which is so hard to do now, this is a problem, speaking to the leaders and really asking what their concerns were. I mean, it helped. And then the community vaccinated their kids against measles. And I think that's happened in other communities of like-minded people, people who share a deeply committed religious point of view, or who are living, or other points of view. So it takes good talk, sensitive talk from people who will go in and say, and not say, you're wrong, you need to listen to us. I think that messaging never works. And I think public health officials have learned that over the years. But to say, what are your concerns? I think the bottom line with all of this is people want to be healthy. I mean, people want their children to be healthy and to grow up without these terrible diseases cutting them short or creating long-term side effects. And if people want to be healthy so they can go to work and continue with their family and community life. So I think the good thing is people want to remain healthy. And I think this is something in some ways we can all do, is when we're having conversations with people who are hesitant about the childhood vaccines, I always say, you never say you're wrong. You can say, speak to your doctor, air your concerns. What are your specific concerns? And there are concerns about side effects, about bad batches of vaccines. There's no question this happens. And I think honesty about this goes a long way toward deepening trust about childhood vaccines and about future vaccines in terms of pandemics, which, historians and public health experts have said they've been waiting for this one, and there will be others in the future. So we need to be prepared. And one thing is to think broadly for all of us about how you build trust in a community, because we are so connected to one another.
Absolutely. Yeah, I couldn't agree more. And, you provided, you focused it on particularly the challenges we have in this country, right? As you said, the tenacity of scientific mistrust that we can unfortunately see so much around us, and that we have this, I guess, historical tradition of xenophobia and conspiracy theories and things like that. Do other countries have the same challenges? I mean, is this unique to us or to certain countries and not so much others?
Well, there's definitely the idea of xenophobia and conspiracy theories, yes, have been everywhere at all times and appear in other countries at the current moment. I think we see this a lot in Europe, just with the refugee crisis of what's going on, who's allowed into countries, who isn't allowed into countries. But in terms of vaccine uptake and trust around medical science, we've seen mistrust and a lot of hesitancy definitely in Britain, in the UK. Their pattern of the response to measles outbreaks was very similar to the US. Among a lot of affluent, highly educated communities of people who didn't want to give their kids vaccines, there have been measles outbreaks. And last year, both the UK and the United States lost our status from the World Health Organization of having eliminated measles. So there's definitely similarities with the UK around measles. I think the example of the polio vaccine, which is, had been almost eradicated around the world, but there have been periodic outbreaks, bad outbreaks in African countries and in parts of India too, over the last, I would say, decade, has to definitely do with mistrust and conspiracy theories. Their problems are different than our problems in terms of what foments those kinds of theories. So when you have a history of colonialism, which goes back hundreds of years, there's already a great basis for mistrust of somebody coming in from the outside saying, I'm here to give you a polio vaccine. Because a lot of the pushback and a lot of the fear is that it will kill that this is going to kill our children, not prevent our children from getting polio. Because there's this underlying fear of somebody coming in with expert knowledge that isn't indigenous, that isn't local with them. So I think in terms of polio, which is really facing an uphill battle in terms of final eradication around the world, the issues around there really have to do with fear and mistrust that are different from those in the United States.
Okay. On such a polio, measles, these diseases that were much more a problem in the past, right? Or certainly affected people on a much larger scale. Some have said they've linked vaccine doubts to this lack of memory of what those diseases did and the absence of experiences firsthand with them. Do you think that with COVID-19, because there is this urgency and there's immediacy and there's a visibility on a connection to it, that will break down some of the doubt or the factors that contribute to hesitancy?
Well, it's hard to know. And there's so much pushback against doing anything that comes as a government order or public health order right now that, I don't know. It's very interesting about how politics and public health come together differently in different historic periods around this. I mean, many doctors today say they've never seen a case of, diphtheria, for example, or some of these other, or smallpox for sure, that have been wiped out. And a lot of public health experts say that vaccines are the victim of their own success. So when physicians don't know the early signs of certain of these diseases, but more importantly, when the public doesn't see them as an immediate threat to their children or their families, it's hard to understand that could actually still be a risk. In other words, a lot of the psychology literature shows that we're actually afraid of things that aren't high priority to be afraid of, and that we should be afraid of things that are below our daily radar. So this is one of the things that's happened with the childhood vaccines, is that when you don't see a case of diphtheria or measles or mumps, you think, well, people got these in the past, or my grandmother had that and she's okay, or my parents had that. They think that this isn't a problem. But we know with measles, just in the last few years, that children still can die of the long-term or the short-term side effects and the problems created by the measles disease. So these problems which we don't see are still with us. I think with COVID-19, it's somewhat different. we see it, but the way we interpret it is so variable. And this has to do with our diverse public. And, you know, as of the news today, there's still websites and online media and radio media that's saying it's a hoax. And, you know, it's hard. It's hard to know what to do with that when the death figures are going up. I think if people don't see this in their own community or don't see the effects of illness on someone they know personally, it's hard to see it as a threat in the same way as somebody who's been living in New York City these last months, let's say, or people now. I mean, I don't know what the general statement is going to be coming out of folks in Florida, you know, in the next month or two. I mean, as we see these outbreaks in different states and different communities around the country, you know, we may be able to chart these different graphs going up and down of what you say, this sense of urgency about a vaccine and a desire for the vaccine. 70% of these, in this last survey, people who say they would take the vaccine may be enough, according to some of the experts, for good enough herd immunity. There's so much still unknown about how a vaccine will respond in our bodies. And we don't know if there'll be long-term immunity and what this will mean. So there's still a lot of uncharted territory ahead, as we see every week in what's going on in the United States.
Absolutely. Yeah. And, you know, there's so much talk about and concern about vaccines as well as treatments, right? Medicines, therapeutics. Do we see the same thing happening with antiviral medications, for example, or is that a way that there might be hope for less resistance or hesitancy in a scientific medical?
Well, it could be. It could be. I think what's in the news all the time now is about vaccine development, and that there's, I can't keep track, but I think there's 10 or 12 different vaccines under development by different companies. Some, and they're with many different types of science going on. We heard some of these in the three presentations before this one. So I think the news is really around the hope for vaccines and where are we in this process? How close are we to massive distribution? But I think, you know, the AIDS example is a good thing to be reminded of. I mean, for how many years? 15 years, there's been a search for a vaccine, maybe more than 15 years. But what's ended up is the success of the antiretrovirals, and that has been wonderful and incredible in keeping people alive with HIV/AIDS. So, you know, it isn't clear yet, absolutely, what will pan out in the United States. I mean, I think vaccine development and the various stages of clinical trials are going to keep going on, definitely through this year and well into next year. But the antiviral search, that may start to pick up in a bigger way as 2021 goes forward. I don't know.
Yeah. Well, we have a lot of questions coming in for you. So I will stop with mine and go to others. The first one being from Niels, who asks, many people feel that they've lost control over their lives in the face of technologies that they don't understand, social inequality, and now a health crisis. How can public health communication help people regain a feeling of control?
Yeah, of course, that's a very important question. It's sort of the question, so thank you. Well, the thing is, there has to be this constant messaging. And when our federal leadership gives a message that is diametrically opposed to what the head of the CDC and Anthony Fauci give, it's very hard to know unless you have a pretty good science education or a medical education. Or, you know, you've been trained to follow a certain line of reasoning, excuse me, about science and medicine. So conflicting messaging is one thing, and then changing messaging, which is what we're getting from the federal government and from state officials as well, is also very confusing. So the messaging around opening up, closing down, opening up, closing down. which is what's going on right now, definitely in California. I don't know if we're going to see it in Texas and Florida right now, or how we're going to see it. But different states are going to keep going back and forth on this. It's sort of a ping pong. And in terms of your listener who answered the question, it makes it very difficult, no matter where you're living in the United States, when you see this going on. You know, I don't know if I can go to a restaurant and sit outside, or I don't, you know, if my gym opens, should I go there? Look what's happening here, look what's happening there. And the messaging is different by different state officials. So the most important thing is consistent messaging, which we're not getting, which is scientifically literate. And I think the more we, the public, can enable that through just our community lives, however they're constricted, which they are so much now, it's to the good. And if we can contact our local community public health officials and say, what can I do locally? You know, here's where I live. Here's as far as I can walk and be socially distanced. I mean, that might be useful. I think, you know, grassroots efforts are good. We've certainly seen this in recent days. So, I mean, but, you know, our nation is so big and so diverse politically and in terms of vulnerabilities that it's really critical that the messaging be consistent and applied to the susceptibilities and vulnerabilities in different locations in the country. And it's been incredibly difficult to achieve this. We're too huge. We're 330 million people, and a lot of states and a lot of different political viewpoints. So it's a very complicated task. And this pandemic has shown us that it, you know, maybe it's impossible. I hope not. I try to be optimistic.
Thank you for that. Yeah, but agreed. It is enormous. And thank you for those great points. And Christina would like to thank you for an excellent presentation. I concur. She says that as someone who has done a lot of research about end of life, could you please expand on how the creation and administration of a vaccine may shape end of life, and particularly those with dementia? And she says that she asks this because the pandemic has altered massively in this area, you know, with respect to the provision of end of life and palliative care. And thank you in advance for your
Wow. Yes. Yeah. Of course, the effects of the virus on the elderly are well known, and they were probably the first group of vulnerable and susceptible to reach a national audience in terms of the nursing home population that was so affected initially, and of course still is. And what we do know is that most people who are in nursing homes have one or another form of dementia. They can no longer live in their own home. They need greater care. Now, whether or not they're getting that care, of course, is a big issue around nursing home reform, which is another topic. But around dementia and end of life, I mean, there's big questions about this anyway. I think the talk that started in March and maybe early April around, well, it's okay for the elderly to die and those with dementia to die, let them die, may the fittest survive, a kind of social Darwinian viewpoint, that has been roundly criticized by a number of my colleagues and by others in the media and in healthcare delivery. Because, well, for all obvious reasons, and you can't, you know, to isolate or bring out one vulnerable population means that, of course, we could, in a policy way, think of other vulnerable populations that, well, why not in a social Darwinist framework, philosophical and ethical framework, why not just let them die? And, you know, this is just ethically abhorrent. We can't do this in a democratic society. The other thing I think that's so important, coming back a little bit to your listener who asked the question, is, you know, we're all vulnerable. We're all susceptible in one way or another. I mean, you know, I don't know the statistic, but how many of us have chronic conditions that make us more vulnerable to the virus than the absolutely healthy 20 to 30-year-old who never goes into a healthcare center and has absolutely no confounding conditions that could interfere, that could make the virus worse. So so those are sort of some background issues. In terms of dementia and end of life, well, there's huge problems around this anyway. I think hospice is a good thing. I don't know, hospice around dementia care is something that is not universal. And people can sign their own advance directives. People work with their families. There's a huge range of opinion about how to handle advanced dementia and where people with advanced dementia are located, if they're in an institution or if they're at home, and what the caregiving situations are like. So there's this great variability around this, as there is with anything else. I think some families will want to give the vaccine if it becomes available to their family members with dementia. I think some family members will choose not to. And it isn't just dementia here. I mean, any other very, very compromising neurological or end of life condition is going to raise questions for health professionals and families once a vaccine is here about, are they entitled to get the vaccine, or should they be among the first? Are they the most vulnerable to get the vaccine? In other words, the ethical opinion could go in either direction. I think one of the things about this pandemic that is so unknown is our response as every single phase of this opens up. And I think once the vaccine is available, and this question of who gets it, who's first in line, who's most vulnerable, and or who's first in line, is going to be a big one. And it's going to show itself in nursing homes and around those persons in end stage dementia. And I think their families and their healthcare providers are going to have to really look at this carefully. I don't know how this is going to unfold. I don't think any of us do. I hope that starts to, work around the edges of your listener's question. I certainly can't provide how this is going to go.
You absolutely did touch on some really important things, and again, to recognize the scale of these challenges and the unknowns. Once we get to this point, right, talking about and looking towards and having the thing, what happens then?
And, regarding this, I mean, what will be the grassroots advocacy around the relationship of the vaccine to end-of-life care, as what will be the grassroots advocacy around any vulnerable population? I think, we are going to see protests, as I said, by those who feel that they're shunted to the end of the line. And I think this is going to vary from community to community. Those with very elderly, very vulnerable relatives who are near the end of life are going to have a different sense of priority, who's vulnerable and what to do about the vaccine, maybe, than communities where there's lots of parents with young children and they're facing issues about, how do we mix this vaccine in with all the other childhood vaccines? So I think it's going to be a mixed bag in terms of the advocacy and pushback and talk around the usefulness and the desire for this vaccine among different communities.
Well, our next question is getting back to those who might have doubts, right? Dealing with vaccine hesitancy, those who may not be sure whether they desire it. It's a question from Steve. Has the health community and have politicians considered using financial incentives to get people vaccinated, such as a tax deduction?
Oh my goodness.
To minimize corruption, we need to do a setup through a database with the IRS or some other agency, perhaps.
Oh, that's interesting.
Yeah, do you know anything about this? Or
I don't know anything about this.
Okay. Yeah.
Look, I think, I hope there isn't broad scale corruption. What can I say? I think there will be people in high up political places who want the vaccine, who will get it first, even though they are probably not considered the most vulnerable or susceptible to the disease and aren't in the number 1, 2, 3 priority rollout. I mean, I think that's going to happen anyway. But you know, how the government keeps track of this is an open question, or how states and local public health departments keep track of this is another. I think maybe local communities, the local public health departments can probably keep track of this better for their community. They are keeping track, at least now, you know, for knowing how many people, how many tests are available and how many people are getting tested. So I think it might be at the local level. In terms of a broad database, I don't know. I mean, you know, there's so much wonderful creativity in this country and entrepreneurship.
Right.
I mean, I think people will just take this on and figure out what to do.
Well, you know, it is an interesting issue, and we've now got another question that is related, talking about asking. So, in addition to education, and I guess maybe financial incentives, are there any discussions about any other incentives for vaccine hesitant people? I guess perhaps certain locations or activities that would only be allowed to those.
Well, yeah, this is the issue about school or work entry. I think, you know, the incentive issue bleeds into coercion. And, you know, I think the incentive is we want good health for ourselves and our families. I mean, I think that has to be the incentive, and it has to be named loudly and clearly and often. I think that's really the issue here. You know, it's really interesting I've, you know, done work on kidney transplant and what's going on internationally in that world of kidney sharing and kidney donation. And there's been talk for more than a decade on, you know, incentives, because in terms of the United Network of Organ Sharing, the number of persons in need for a kidney transplant far outpaces the number of people who have, the donors who are available. So the health community is constantly thinking about how do we raise supply to equal demand. And there's talk forever, nationally and internationally, about providing financial incentives. And this talk never settles. It never settles. There's arguments on both sides all the time. And I think, I have no idea if that could be a comparison situation to this, but I think the incentive is we want to prevent the disease, we want to dampen the disease. And I think, you know, this other important thing is our connection to each other, how we are joined at the body politic. So in other words, when I have the vaccine, it might prevent the disease in me, but it is also helping those vulnerable who I run into in the grocery store, or when I take a trip somewhere to another community where more people are vulnerable in some way to the virus. So each individual's decision to be vaccinated goes one step farther to helping other people in our community. And I think, you know, the empathic and altruistic instinct is strong. I mean, we help each other. I mean, look what's going on, you know, in food delivery and food banks. And whenever there's, you know, a flood or a hurricane or a crisis, we reach out, we help each other. And I think, you know, the incentive is that. I mean, it isn't just protection for yourself. It is you are helping your community. You are helping people you will never meet. You will never know personally, but you may prevent one person, 10 people from getting the disease caused by this virus. And I think that needs to be the incentive. And we need to not go into the muck and mire of the ethical quandary of financial issues around this.
Yeah, no, I think that by appealing to the best instincts and motivations in people, that, you know, we can see you know, this kind of positive, you know, action and change. And I've got time for one more question. And actually, yeah, I think that you know, it's been somewhat addressed. I mean, what you just said. But if you want to maybe reemphasize anything, because I think that our listeners, our audience, has been thinking a lot about what you're saying. And Philemon is asking here, when and how should we be planning for a COVID-19 vaccine? What ideas do you have? on how we can bring communities along and get their buy-ins in advance. I don't know if this is a question about, if the we here is what can we do at the grassroots level, those of us who aren't waging, vaccines, or that maybe we more generally as a society, and however you want to take that.
Well,
please.
Yeah. Okay. Yeah. I think some of the things I've said hopefully address that in one way or the other. I think your listener wants me to try and pull it all together. I will say that one of the things I am aware of that's in the news and I've actually heard is the problem down the road. And I think a couple of your scientists have actually mentioned this also in the previous programs is, look, there's going to be side effects. There's going to be untoward effects that may not be known for 6 months or a year down the road. I mean, when you vaccinate more than millions, more than 2 or 3 or 4 or 5 million people, yes, there are side effects. Yes, we have this, we have a system in the government for tracking this and for reporting that, vaccine incidents, adverse incidents. It's a website. And it's highly likely that there will be side effects, all kinds of side effects. And will these be mild, like, a sore arm for a day, or will there be some that can't be anticipated yet by the scientists who are working on the vaccines and the clinical researchers who are going to be, who are already starting with the clinical trials, but I'm sure they're looking at this. So, just to take a segue here a little bit, when they do these clinical trials on certain populations, other populations are left out. And here's another thing that is well known and has been fought against for years, is that the elderly are left out of clinical trials historically. Because why? Because they have confounding medical conditions that will muddy the waters for the clinical trials. And investigators want things to be as clean as possible. Otherwise, they're not going to be able to see positive effects of whatever therapy it is that they're working on. So people over 65 and 70 have been left out of clinical trials. And there's been a huge push, for 20 years, to make sure that the elderly are included in clinical trials. And we actually went through this already 15 years ago with having more minorities be included in clinical trials. That's happened. Now, because the coronavirus is affecting more elderly, more are going to be included in bigger clinical trials. I don't know if it will be proportionate to the population or how this is rolling out. But regardless, people who are enrolled in clinical trials do not represent the full population. And when the thing is rolled out, in other words, in some ways, a new vaccine, when it's rolled out into the full public, is its own experiment. It is its own trial, because we don't know what the effects are going to be broadly. So to get back to your listener's question, I think one of the things that's going to happen is some people who want the vaccine are going to say, I'm going to wait 3 months. I'm going to wait 6 months. And then I'm going to read the scientific literature. I'm going to read the newspaper. I'm going to read my social media to see how bad the effects are. And if I feel, given my own vulnerabilities, my own susceptibilities, my own level of trust, and my own sense of risk, will I then take the vaccine? I think a lot of that is going to go on. Maybe I'll be wrong, but I think people are going to want it, as your previous listener who wanted to know about, corruption, people wanting the vaccine right away. There's going to be people who really want it immediately. There's going to be some people who say, let me wait and let me see how this rolls out, especially if I'm if I'm part of a population that has asthma, or part of a population that's over the age of 80, or, something like that. And if, because the effects of the vaccine, any trial vaccine, may not be well known for certain vulnerable groups until this broad scale vaccination.
Well, I think that, that is a really good place to
with a lot of unknowns.
So this incredibly important conversation and series, but I'm so glad that we are ending with a discussion of social science. And certainly we're laying out far more questions than answers at this point, but to be talking about them now is critical. It's the best way to be moving forward with knowledge and awareness of the challenges ahead. So Sharon, thank you so much for this. I really it. I think that our entire audience did as well. And to our audience, I say thank you as well. Some of you have been with us through this whole series. Others may have just tuned in today, but your interest and your participation in this is really promising. For me, it's a very positive sign that in these times of COVID-19, that we are focusing on some of the best things that we can do and ways that we can move forward together with these enormous challenges. So we are at the end of this series. Please keep an eye on our website for more outbreak-related programs coming up. I think we'll be back this fall with more for you all to join. And as we end the program today, please take the survey if you can. We'd love to get your feedback, and it will help us improve our programming for the future. And so with that, I'll just say, healthy and take care. Thank you.